Quality care is equitable care. So to reach true quality at the patient level, we must eliminate disparities.
When my colleagues come to visit the ICU, the striking thing, my other intensivist friends, they look at the patients in the beds in our ICU and they say, they're so young, what happened? How could this be that these patients are so young? They're in the 30s and 40s, and the ages in the other ICUs are 70s and 80s. And so there's a stark difference.
If we don't have data on the outcomes of our patients by gender or by language or by ethnicity, it's hard to attack that problem. And so anybody who's in the quality improvement business knows that you start with baselines.
I don't think that we could give good care unless we know who our community is. And in the community that we're living in, we have to specialize and individualize services specific to the communities.
One of the nurses very early on asked my wife and I what we wanted to be called, mommy or mama or what. And she remembered which of us was mama and which of us was mommy. At a point when, our son was 4 months old, we were sleep deprived and terrified. We couldn't remember ourselves. She got it right every single time. And that just made a huge impact on me, that I felt like she really saw us.
We're going to recognize that we need to go to where the people are. And in Toyota and Lean, we call that the Gemba, where the work is done. But as we change our mental model to health and intervening where people live, it changes the Gemba. It changes where the work needs to be done. It changes how we see things, and how we see determines what we see and what we focus on and what we spend our money on and the outcomes that we're looking for. We need to change our mental models.
We have a meeting here called the Reentry Solutions Meeting. We've been meeting for about 3 years, and it is a lot of community-based programs, a lot of faith-based programs, a lot of program, and even department head, chief of probation, the sheriff's department, just all these different entities, and no providers are at the table. Providers need to be at those tables, so they'll know exactly where they're fitting and what's going on in the community that they're serving.
In order to truly achieve quality across the board for all patients, we have to address the needs of specific populations, because it is those populations that are often lagging behind.
The promoters work with doctors, nurses, and all staff in the clinics, and we help to doctors and patients. We are in the middle. We are the bridge for the community and the system.
One of the things that I really saw through our experience at the hospital is that this kind of respect can be institutionalized. I have lived it, I have experienced it. We spent 4 months in an intensive care unit and in a hospital and in a system where we were treated with respect from top to bottom, from the attending physician to the parking lot attendant. And I got clear that this wasn't just a coincidence, it wasn't just that we happened to live in a liberal part of the country. Something specific had happened at this institution, that somebody had prioritized treating people with equality and with respect, and clearly somebody understood the value of this in terms of its impact on health.
To provide high quality care with everyone of necessity involves being attuned to not only the physiology of our patient, but something about the social context and circumstances of our patients. If by quality we mean the broadest definition of quality, and not what professionals have tended to focus on, which is a fairly narrow slice of the clinical decision to be made, I think disparities will, if not disappear, be largely minimized if we can figure out how to get the social context right that allows patients to actively participate in the management of their own disease better.
Being a part of that quality healthcare means that they're more likely to listen and follow the instruction. And so in doing that, that means that we each one teach one. And now they're going to take it back to the families. You know, if it's something good going on, you want to tell somebody, this is good. Come on with it. This is good. And so you want to bring them on in. You know, come get some of this good stuff. And I think that that alone will help to reduce a lot of disparity.
I think part of our problem is we're stuck in the mindset of disparity instead of equity, just like we're stuck in the mindset of disease rather than health.
In diabetes group visit, they learn how they have to eat. They learn about the medicines. They learn about how they communicate with doctors. It's one of my dreams to give these groups in a many language.
I don't believe that most health systems are doing enough to address health equity, because I don't believe we truly understand the scope of the problem.
I wasn't taught to navigate healthcare with my parents. My husband was not taught to navigate healthcare. And that was the greatest gift that I could give to our kids, was to teach them how to care for themselves when they turned 18, how to call and set up an appointment, to follow through with the appointment, and to get their healthcare needs met.
We all signed on to provide high quality care for every patient that sees us. And providing high quality care for every patient that sees us while avoiding the inevitable conscious or unconscious presumptions that we have rests on providing evidence-based care in a standardized way while it needs to be customized. So I think actually the development of less art and more science in healthcare is one of the most powerful engines for overcoming disparities, because it can minimize the operation of individual, I'll call it prejudice, conscious or unconscious, in the way we treat patients.